If you only remember one vasopressor, make it norepinephrine. What's up, you guys? It's your ER pharmacist, Lil Pharma. We are in part 3 of our vasopressor boot camp, and today it's all about norepinephrine. Norepinephrine is primarily an alpha-1 agonist, so it's going to squeeze those vessels in the periphery, cause vasoconstriction, and increase systemic vascular resistance, or SVR. It also has some beta-1 activity, so causes some contractility, but not as much as something like epinephrine. So overall, more squeeze, less pump, but still a little pump. This is why it's first line for septic shock. So septic shock is a vasodilatory problem. We need to vasoconstrict those vessels to keep the blood in the vessels and getting to the tissues that it needs to perfuse. So new SCCM guidelines came out. They continue to recommend norepinephrine as our first line in septic shock. So of course, nothing is perfect. Adverse effects associated with norepinephrine, we can see extreme vasoconstriction, especially if given at high doses or prolonged periods, and in those smaller vessels in the extremities. So you can see digital ischemia with this one, not as much as some of our other vasopressors, but it can happen again at those high doses or prolonged infusions. We can still see arrhythmias, again, not as much as our other agents like epinephrine or dopamine that are more active at those beta receptors, but it can happen because it does have some stimulation at those beta receptors. If it extravasates, this is a big issue because it's going to vasoconstrict all those vessels that it's near and can cause ischemia. Luckily, we have reversal agents for this, but monitor your patient closely, put it in a good vein. When not to use norepinephrine, shock states. So cardiogenic shock, it could work and give you some time to figure out what's going on with your patient, but it's not necessarily first line. We might want to think of something that has more inotropic effect like dobutamine, milrinone, or even epinephrine. And then the other situation is going to be hypovolemic shock, which we're not going to want to give any of our vasopressors to because that's more of a volume issue than actual need for squeeze in the vessels. So if you need more squeeze and a little pump, norepinephrine is your best friend. If it's septic shock, norepinephrine all the way. Other shock states, undifferentiated shock states, norepinephrine is usually a good first choice until you can figure out what's going on with your patient, and then you can optimize your vasopressor therapy from there. But like I said at the beginning, if you remember any vasopressors from this whole boot camp, remember norepinephrine because that's going to be your go-to in most situations. All right, that's what I got for you guys. Come back for more in this vasopressor boot camp series. I'm so excited. Like I said, I love talking about vasopressors, so keep coming back.